Hi, this is Elliot Fishman, and welcome to part 3 of our talk on the CT evaluation of suspected small bowel obstruction. We're going to do and pick up where we left off last time. We mentioned about hernias. Now, one of the causes of small bowel obstruction are hernias. Hernias can occur for many reasons. The classic one is an inguinal hernia. We talk about incisional hernias. We talk about internal hernias like lesser sac, but we're going to talk about the hernias that typically go through spaces like the inguinal region or through muscle defects or through post-surgical scars. Now, again, in terms of how do you pick up a hernia, well, we're looking at the small bowel. We're looking for transition points. You can see just looking at the axial image here, there's some prominent enhancement, and you see a dilated loop of bowel, and then you see a loop going down into the hernia. Now, of course, we have more than these two images, and you have this. You have the typical coronal display nicely showing you the layering of the bowel loops. And so you know you're dealing with obstruction literally from about this scan, and then we're following it down and down and down. And then here we see the transition very nicely shown that the bowel loop is going in the hernia. Now, sometimes you can reduce some of these hernias surgically at the bedside and not need to go to surgery, but most of the time you typically can't, and you're worrying about perforating the bowel. When I look at these hernias, the fact I see a little bit of fluid in the hernia sac makes me worry about ischemia. Once you worry about ischemia, the patient, whether you can reduce it or not, is going to go to the OR. So just a very nice example. We see the mesenteric vessels are patent, though branches off the SMA, the vasa recta, are a bit dilated. There's prominent mucosal enhancement of a small bowel, but just a really nice example of a classic inguinal hernia. And here it is very nicely shown on the sagittal view as well. Again, making the point that I like to follow obstruction downward interactively, but that the coronal views are especially valuable. But in this case, the sagittal is also helpful. External hernias are the second most frequent cause of bowel obstruction. They can occur throughout the abdomen and pelvis, but most frequently involve the inguinal canal or anterior abdominal wall. The hallmark of small bowel obstruction due to hernia is the presence of dilated bowel up to the hernia sac, followed by decompressed bowel exiting from the hernia sac. And sometimes, of course, it goes in, but doesn't exactly come out. Another example, markedly dilated small bowel. There's no doubt we're dealing with a small bowel obstruction in this case, and we track it downward. The mesenteric vessels are a bit to the right of midline. So is there some twisting of the vessels? But I don't know, but they are patent so far, but there's lots of dilated small bowel. And then we track this down into the pelvis. There's the dilated loops. And here we see a left inguinal hernia. And you can see it's coming here and here on the axials. So we know we have a left inguinal hernia. We'll look at it a bit better, and here it is nicely shown on the coronal views. There's the twist right here. There's the hernia. There's some fluid here. You have to worry the patient has ischemic bowel, which they did have at surgery, but the hernia was reduced, some bowel resected, and the patient did fine. Just a very nice example of a left inguinal hernia. And you could see the hernia contract, as in this case it did, down to the level of the patient's scrotum. Here's another example. Small bowel obstruction, and we'll look carefully. Dilated small bowel, we follow it downward like the last case. We're tracking it down, and then we track it. There's the twist here where it's entering into this hernia, into the patient's right inguinal zone. And in addition to the patient's small bowel herniation, there's also large bowel, so the cecum is also herniated. This patient obviously is going to surgery. Fortunately for the patient, they did have ascites, so they did need to have some of the small bowel resected, but the patient did fine. But it's a good example of large hernia, transition point, and fluid in the hernia sac. Again, very nicely shown here on the volume rendering on your right, on the routine coronal on the left. And here's a cinematic rendering really showing you those dilated loops of bowel, the hernia of cecum and terminal ileum, and the patient's obstruction, and the patient going directly to surgery. Again, one of the things we are looking at with cinematic rendering, can you pick up ischemic bowel by looking at the changes in bowel wall edema? With ischemia, bowel wall edema increases. The question is, how accurate are you in that diagnosis? But in a case like this, you know the patient whether there's ischemia now or can be present later, is going to surgery because there is only one way to manage this patient. Now, we mentioned also hernias due to prior trocar zones, prior surgical zones. Here's a hernia in the midline, defect in the rectus muscle. There's some inflamed fat. Then you look at the sagittal view. There's a loop of bowel tracking in, a little bit of free fluid. That's a hernia in the patient's abdominal wall, nicely shown through a defect, which was due to prior surgery. Here's an example of a patient with left lower quadrant pain. Stomach's distended, gallbladder show nicely, pancreas. We follow it down. We see the dilated loops of bowel. Then we see a defect in the patient's left rectus muscle. Here's the loop going through, and it almost looks like it's going through and trapped, kind of the narrowing point going in and the narrowing point coming out, which we talk about as a hernia. Here it is on the coronal views, very nicely showing you all of the small bowel loops layering out. And here's the hernia sitting right there. And it's going right through the muscle, very nicely shown again on the sagittal view. This will need to have surgery, the patient, and have that repaired. This hernia goes by a special name. It's a defect in the musculature. You see the bowel going through the hernia and being obstructed. Here it's very nicely shown. There's that knuckle. Often on physical exam, you'll feel like a mass here. And it's the hernia you're palpating very nicely on these cinematic rendered views. Again, the dilated loops, stretching of mesenteric vessels. There's the hernia through a defect in the patient's lateral musculature. And this is what's referred to as a Spigelian hernia in the left lower quadrant. And Spigelian hernias are ventral hernia, which is defined as herniation of abdominal contents or perineum through a defect, namely the Spigelian fascia, which is comprised of the transversus abdominis and the internal oblique aponeurosis. Patients may describe a painful or painless bulge. Remember, that's what I showed you on the cinematic rendering. Particularly when standing, there may be acute or chronic in onset. Depending on the contents within the hernia, pain may vary greatly in terms of severity, character, or location. Commonly, patients will present in the urgent setting, secondary to complications associated to the hernia. So again, this patient has a small bowel, it's obstructing. This patient will need surgery. Another patient, large mass, palpable mass, left lower quadrant. CT shows a large defect in the patient's rectus muscle. You can see on the left the bowel is going through the hernia. The bowel is thickened, inflamed. The mesenteric fat is inflamed. There's ascites present. There's haziness present. And the key finding about this haziness and the trace fluid, this is a patient, regardless of why we think the patient has the hernia, is going to surgery. Because in our experience with haziness and ascites, you're going to surgery. Very nice example showing you the same case on the axial, but also nicely showing you this loop on the sagittal view. You can see it comes in, but that loop is edematous. You know you have to be concerned about ischemia. There's some of the edema there. There's the defect. There's the herniation point. And again, very nicely showing you the haziness of the mesenteric vessels as well as the fluid being present. Now, I also mentioned before in terms of hernias, we looked at adhesions, we looked at hernias. In small bowel obstruction, tumors are less common, but they do occur. So in this case, in a patient with obstruction, you see a mass of the tail of the pancreas involving the small bowel, distal duodenum, and proximal jejunum by the ligament of Treitz. So tumors not of the bowel can involve the bowel. And this is a nice example of showing you the duodenum and jejunum being obstructed by a tail of pancreas lesion. More commonly, patients' pancreatic head tumors can involve the duodenum and cause obstruction as well. Just a very nice example showing you how we look at the dilated bowel and then look at the transition point, and it's very easy to make that diagnosis. Another case, here we see a dilated duodenum, and then the duodenum is infiltrated, it's thickened. It's not Crohn's disease. This is more significant thickening. It's bulkier. There are multiple nodes present around the bowel, which you see small nodes with Crohn's, but you don't see Crohn's that often alone in the duodenum and in the jejunum. And here you can see very nicely the dilated duodenum, then the transition with the infiltration of the bowel. A very nice example of a malignancy, most likely, again shown on cinematic, most likely it's going to be adenocarcinoma. Lymphoma is usually bulkier. GIST tumors are larger, typically exophytic. This is infiltrating, and carcinoma, primary small bowel adenocarcinoma, is the best diagnosis. Again, the transition point very nicely shown on the patient's cinematic rendering. Other tumors, lymphoma. Lymphoma has a range of appearances, from polypoid lesions to large bulky lesions to ulcerations to the sandwich sign, which is encasement of the mesentery. There's some displacement of bowel, but you can see the infiltration. Lymphoma is the tumor we talk about encasing vessels, narrowing vessels, not occluding vessels. We talk about lymphoma infiltrating, in this case infiltrating into the mesentery, involving the bowel secondary with mild bowel dilatation. You can see polypoid masses in lymphoma. You can see large ulcerating masses, and this really nice appearance of diffuse infiltration of the mesentery with encasement of the vessels and involvement of the bowel. And here it is again nicely shown on the patient's cinematic rendering. A really, really nice example of that. Now, when we talk about lymphoma, this article by Leroux made the point about polypoid pattern and infiltrative patterns. We know lymphoma is a great mimicker. We don't see primary lymphoma all that common as just bowel. Often when you have bowel involvement, you'll see liver or splenic involvement, maybe renal involvement. This case, infiltrative form, is something we need to think about. The infiltrative form of lymphoma can easily be confused with adenocarcinoma, and that's true both in stomach and small bowel and large bowel. Now, another thing about bowel presenting with ischemia, look at this case. The small bowel distally is markedly dilated, and the mucosal pattern shows increased enhancement. Could this be inflammatory bowel disease? I think so. Could this be ischemic bowel? I think the answer is yes. But as you look more carefully, there's a mass in the mesentery with calcification, there's small nodal masses, and there's a desmoplastic reaction. And when you think about that, you're thinking about carcinoid tumors. Mass in the mesentery with calcification, sclerosing mesenteritis, and carcinoid tumors up to 70% will have calcification. Desmoplastic reaction is more common and more extensive in carcinoid rather than sclerosing mesenteritis. And here you see that pattern of desmoplastic reaction, which is causing the bowel wall thickening, and you're developing ischemic bowel. So carcinoid tumors can easily lead to ischemic bowel. I think a key thing in this case also is to recognize the cause of the dilated bowel. This is not a case of Crohn's. This is not a case of adhesions. There's a mass in the mesentery. There's desmoplastic reaction with secondary involvement of the small bowel, which again is nicely seen here on the cinematic rendered views as well. In looking also at obstruction, patient with abdominal distension, here's a good example of what I would call pseudomyxoma peritonei, diffuse infiltration of the omentum and mesentery, extensive tumor. This can be due to underlying causes like ovarian cancer, gastric cancer, colon cancer. There are a range of tumors that give pseudomyxoma peritonei, this very impressive appearance. Interesting, the bowel is minimally dilated, it's not obstructed, but with pseudomyxoma peritonei, it will commonly be obstructed. Again, mucinous tumors, common duct, appendix, and pancreas are all possibilities as well in the differential diagnosis. And this article by Carande, the diagnostic sign on CT, low attenuation ascites with implants. These implants, as you know, can cause obstruction, and sometimes the patient's presentation is with carcinomatosis, and this could be due to a range of causes. And the pattern of carcinomatosis can look the same in all of those cases. I always like to mention pitfalls. If I look at this case, I would say carcinomatosis, and then I would argue ovary, stomach, you name it. This ended up being, that's what everyone assumed, but this ended up being tuberculosis. TB peritonitis can look identical to carcinomatosis. It's rarely seen in this country. This was a case we saw. I've had a few cases shown to me in conference, but every case was the patient came from Ethiopia, the patient came from Uganda, The patient came someplace in Africa. In Africa, where TB is a lot higher frequency, GI TB is common, and that appearance of what looks like carcinomatosis, but it's really TB peritonitis, is one of the interesting cases. Now, another thing we talk about with obstruction, we look for transition points. We may see this appearance, which is an intussusception. Intussusception can be caused by benign tumors or malignant tumors. It also can be caused by inflammatory bowel disease. When you see multiple intussusceptions, as in this patient, you got to think about tumor. Metastasis like melanoma is a good possibility, and lymphoma is a good possibility. Malignant tumors cause 30% of intussusceptions in the small bowel and 50% in the large bowel in the adult population. Adenocarcinoma is the most common pathway and pathology of small bowel intussusceptions. But again, lymphoma, sarcoma, and melanoma, and with the frequency of melanoma increasing, we are seeing more cases of metastasis, though other tumors can have the same problem as well. And again, as we talk about intussusception, we talk about both malignant and benign tumors, but I also mentioned functional causes, celiac disease and Crohn's disease are two possibilities. Also, we can see, and all of you have seen, intermittent intussusceptions in the patient's proximal jejunum. Benign causes of intussusceptions, Meckel's, cystic fibrosis, tumors like Peutz-Jeghers or inflammatory polyps or lipomas are all in the differential diagnosis. Just to show you and reinforce a few cases, nice example here, cross-section. There's the intussusception with the fat being stretched into it. Here it is very nicely shown on the volume rendered image. A really nice look of the intussusception tracking down into the bowel and the appearance classic of intussusception. Again, also nicely seen here and here on the patient's cinematic rendering. I again will look very carefully at the lead point. Is it a lipoma? Then I'll see fat. Is it a solid tumor? Then I can think about things, or do I see nothing and wonder if it's just some other cause that's not a tumor? Just a very, very nice example of that. Now, the thing about intussusceptions is sometimes they're intermittent. We talk about that in the jejunum, but look at this case, small bowel dilatation. Here's on axial views in the jejunum and intussusception. But when you look closely at it, it looks like it has mass effect. Here you see stretching and twisting of the vessels and of the small bowel. There you see the dilated bowel. We see the transition point right here where the intussusception is. This looks not as your intermittent intussusception, which if you scan 5 minutes later, it will typically go away. This is definitely going to be an infiltrating tumor. You can think about primary adenocarcinoma versus lymphoma as possibilities. Very nicely here seeing that intussusception with the dilated proximal small bowel behind it. Again, the intussuscepting mass seen right here as well. And this was a patient with lung cancer and metastasis to the small bowel. So again, there's a range of appearances. Clinical history would be helpful. I mentioned melanoma is the one we think about, but other tumors, including lung cancer, are all possibilities. And here's another patient with adenocarcinoma of the colon with small bowel obstruction. We're following it downward. And here we can see the patient's obstruction. And the patient's tumor in the colon was the cause of the patient's obstruction. Very nice example of the small bowel being dilated, but also large bowel. So sometimes when you have obstruction in the large bowel, you'll see large bowel and small bowel dilated. So it's important not just looking at small bowel for transition there, but looking at large bowel when both of them are going to be involved, and a really nice apple core type lesion sitting right there. Very, very impressive indeed. Now, other causes, here's an example with right lower quadrant pain and small bowel obstruction that looks like a mass in the right lower quadrant with inflammation. The mass here looks bulky. Got to think about lymphoma. Got to think about carcinoma. Could it be a cecal cancer that involves the small bowel? Here you can see the patient has multiple splenic lesions. There's nodes encasing the celiac and SMA, para-aortic adenopathy. Put it all together, it's cecal lymphoma with small bowel obstruction. And again, the extensive adenopathy as well as the splenic involvement made the diagnosis a bit easier to do. So let's do this. I want to continue going through some of the causes of bowel obstruction, some of the pitfalls, but we're kind of out of time for this talk. So let's take a break and come back with this case. And what you notice here, by the way, I'll give you a hint, is there is pneumoperitoneum. There's free air here. So let's come back on this case, and I'll see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.